Thank you so much for joining us today. Welcome to our webinar on Medicare drug pricing negotiation under the Inflation Reduction Act. We are glad to see such a strong interest in what is clearly one of the most consequential policy changes affecting drug pricing and market access in recent years. My name is Lixia Yao, and I'm the founder and CEO of Polygon Health Analytics. At Polygon, we focus on generating high quality real world data and real world evidence to inform decision making across the healthcare ecosystem. This topic sits right at the intersection of policy, evidence generation, and market strategy. So I'm particularly excited about today's discussion. We are fortunate to have two excellent speakers with us, Ina Li and Jianting Shi, who are the co-author of the white paper on the same topic. Today, they will walk us through an overview of the Inflation Reduction Act, including the policy background, how the Medicare drug price negotiation framework actually works, and what it means for stakeholders across the ecosystem, from investors to manufacturers and to patients. Before we get started, a couple of quick housekeeping items. This webinar is being recorded and will be made available afterwards for those who cannot attend live. We'll reserve time for Q&A at the end. Please feel free to submit your questions at any time using the Q&A feature, and we'll address as many as we can during the discussion. With that, let me turn it over to Ina and Jianting to get us started.
All right, so can everyone see my screen?
Yes.
Okay, let's get started. Hi, everyone. In the next 45 minutes, we will be introducing the Medicare drug price negotiation program under the Inflation Reduction Act, or IRA. So we will move through 5 questions. First, why did the IRA, especially the drug price negotiation program, emerge? How does the CMS decide which drugs enter negotiation? And how is the negotiation process conducted? How is the maximum fair price set? Next, we'll be moving on to the changes to policy in IPAY 2028, which just announced beginning of this year, and also cover the other moving parts in drug pricing reform. Finally, we'll have the discussion about the impact across the ecosystem. The first question, why did the IRA emerge? The starting point is the financial strain and governmental fiscal pressure. So US drug prices are much higher than in peer countries, almost 3 times on average, and above 4 times for brand name originator drugs. For many Americans, particularly older adults and people with chronic conditions, these high prices have contributed to substantial financial strain. At the same time, 18% of the US GDP is allocated to healthcare and is the highest among the high-income countries. Further, Medicare drug spending has continued to rise. Out of the total spending in 2026, Part D spending alone is projected to reach approximately 11%. These numbers explain why the policy debate is framed around a patient affordability issue and also a federal financing issue. The IRA emerged because the drug pricing became not only a household problem, but also a Medicare sustainability problem. When we look closely at the Medicare spending, The second pressure point emerges as we found what beneficiaries faced before the IRA reforms. The Medicare is divided into 4 parts, each covering a different type of care. Part A covers hospitalization. Part B is medical insurance. It covers physician visit, outpatient care, preventive services, and some drugs that are administered by providers, such as infusions or injections in a clinic. Part C, or Medicare Advantage, is the private plan version of Medicare that bundles Part A and B and often include Part D. So this Part D is the key part for this discussion. In the old Part D design, there is no hard annual out-of-pocket cap. That means patients using expensive drugs could continue pay co-insurance even after they reach the out-of-pocket limit. And the cost exposure did not truly stop. For a patient who needs a high-cost therapy every month, this structure matters because the burden is not just one isolated bill. It becomes an ongoing liability. And this is why the IRA conversation is not only about government savings. It is about financial risk for patients who need expensive medications as well. In 2003, the Medicare Modernization Act established the Medicare Part D prescription drug benefits and introduced this non-interference clause. It prohibits direct negotiation between human health and human services and manufacturers over drug prices, but leave the HHS with leverage over private plans, formularies, pharmacy benefit managers, and decentralized negotiations. The IRA changes that balance. CMS can now negotiate prices for a certain high expenditure, single-source Medicare drugs that lack generics or biosimilar competition. And this is the legal backdrop that makes the IRA important. It does not invent negotiation entirely. Private plans and PBMs are already negotiating. And what changed is that CMS gained direct authority to negotiate selected high-spend drugs on behalf of Medicare. Now, let's move on to the mechanism behind the Medicare drug price negotiation program. It's a 2-step process. The first step, CMS first select the narrow set of high-spend drugs. And let's take a closer look at the selection funnel. The CMS does not start with a list of popular drugs. It actually starts with statutory criteria. The baseline is the products covered under Medicare Part D or Part B. And then CMS aggregates all dosage forms and strengths that share the same active ingredients and the same manufacturer into a single analysis unit and call it a single source drug. It is determined whether this drug remain single source by integrating multiple authority resources, including FDA Orange Book and Purple Book records, and the average manufacturer price data to verify the marketed status of generic or biosimilars. The evidence of marketed generic or biosimilar competition for the same active ingredients disqualifies the product from single source status and thus excluded from negotiation. A drug covered under Medicare Part B or Part D may be a small molecule drug or a biologic, and this criteria apply different time on market threshold before CMS may initiate the assessment. It's at least 7 years after approval for small molecule drugs and 11 years for biologics. This reflects the scientific and regulatory differences between these product types. And then it also applies rule-based exclusions for orphan drugs, low-spend drugs, and plasma-derived products, as well as products from small biotech or with biosimilar entry delays. After applying statutory exclusions, CMS formally selects the highest ranked remaining negotiation eligible drugs for negotiation. And here is a good example. And it's from the IPA 2027 selected drugs, Ozempic, Ribosys, and Wegovy. These drugs are grouped as a semaglutide family because CMS look across dosage forms and strengths tied to the same active ingredients and relevant application holder structure. The eligibility clock is anchored to the earliest relevant approval, which in this case starts with Ozempic rather than the later Ribosys or Wegovy approvals. And this group was not removed by generic or biosimilar competition screen or the main statutory exclusions. Then the spending become decisive. CMS identified this group as the selected drug with the highest Part D spending in 2024 among the IPA 2027 selected drugs. And this case together shows the hidden logic of the funnel. Aggregation, eligibility clock, exclusions, and spending rank all matter. Here, there is one point worth further emphasis. A drug that have high Medicare spending does not necessarily be excluded, will still be excluded from the negotiation pool. The IRA targets where Medicare dollars concentrates while protecting the incentives that fund innovation. On one hand, CMS screens for whether the drug is single-source drug without generic or biosimilar competition to discipline prices, and whether the exclusivity window has passed, and also where negotiation moves the budget most. On the other hand, CMS protects what the law shields, and that is where a statutory exclusion applies. The selection is not simply a top spend list. It is a legal and operational narrowing process. And every rule balances two goals: cut spending where it counts without taxing the innovation that creates new medicine. So once a drug is selected, the process changes from filtering to negotiation. Manufacturers enter the participation agreements, submit evidence, and manufacturer-specific information. CMS develops an initial offer. Manufacturers can respond with counter offers. And the process can include negotiation meetings and revised offers. At the end, CMS publishes the final maximum fair price and an explanation. This sequence is important because the program is not an informal bargaining conversation. It is a structured process with deadlines, evidence inputs, and enforcement consequences. So one of the most significant consequences in this negotiation process is the maximum fair price we just mentioned. It is easier to understand if we call it a cap price. There is a statutory ceiling that defines the upper boundary. Within that boundary, CMS considers therapeutic alternatives, comparative clinical benefits, and the manufacturer-specific economic information. And the result is the MFP. So that means the price is not chosen from nowhere, but negotiated downwards from a statutory ceiling and weighted against the evidence. That is why the MFP is both a price and policy signal, It shows how Medicare is beginning to operationalize value, spending pressure, and the statutory constraints. So with the mechanism explained, here is the timeline of CMS implementation. The IRA was enacted in 2022. The next year, the first 10 drugs in cycle 1 were selected, and the corresponding MFPs were published in 2024. Last year, in 2025, another 15 drugs in cycle 2 were selected. From this year, multiple milestones will be rolled out in the same year. For example, in 2026, cycle 1 prices take effect, and the selection of another 15 drugs for cycle 3 was announced. And next year, cycle 2 prices will take effect, and from then on, CMS will select up to 20 selected, will be up to 20 drugs annually. Now let's look at the results from the previous selection list. The first cycle in IPA 2026 established the baseline. It proved that the program could move from statute to operation. And CMS selected 10 Part D drugs for IPA 2026. These included widely used products across diabetes, cardiovascular disease, autoimmune disease, and oncology-related indications. The main takeaway is not only the number of drugs, but the fact that the first negotiated MFPs became real Medicare prices starting in 2026. This cycle gave CMS, manufacturers, plans, and policy observers the first working model of the new system. And the second cycle expand the program from 10 to 15 Part D drugs and shift the mix towards major specialty and high-spend products, including the GLP-1 semaglutide group. CMS estimated larger savings in the second round than the first round. It reviews that not every cycle will move in the same way and that the program is not static. The selected list, the product mix, and the savings profile can change meaningfully from one cycle to next. Now let's take a closer look for what's changed for IPA 2028. The 2028 cycle is the real inflection point because the program scope changes. There are 4 main policy changes. Part B drugs enter the negotiation framework, and Medicare Advantage data becomes important for measuring spending more completely. The One Big Beautiful Bill Act reshaped the orphan drug boundary. And then the renegotiation pathway begins. This is why the 2028 cannot be considered as a simple cycle 3. It's a new phase in the program. For the Part B integration, cycle 1 and cycle 2 focus on Part D drugs, which are generally dispensed through pharmacies or mail order. Starting with the 2028 cycle, Part B drugs enter the selection process. These are often the physician-administered drugs, such as infusions or injections used in a clinical settings. That matters because Part B has different payment mechanism and different stakeholders and different access concerns. The program is no longer focused on only one retail drug spending. It begins to touch drugs embedded in clinical delivery. So if the goal is to rank drugs by Medicare spending, the data source really matters. The Medicare Advantage now covers over 50% of Medicare beneficiaries. If CMS looked only at fee-for-service claims, it could miss a substantial portion of utilization, especially for Part B drugs. That is why Medicare Advantage encounter data matters. It gives CMS a more complete view of where drug spending actually occurs across the delivery models. In practical terms, better data changes the selection pool, and the selection pool determines which drugs face negotiation. Now, when it comes to the OBBBA, this policy changes the orphan drug boundary in two important ways. First, the orphan exclusion becomes broader for products whose approved indications remain within rare disease. Second, for orphan first drugs that later receive a non-orphan approval, the eligibility clock can start later. This matters because the clock determines when a product can become eligible for negotiation. And in simple terms, the OBBBA can delay exposure for some products and narrow the future pool towards broader markets, non-orphan drugs. So here is a case study. We're going to talk about the Keytruda, which is a useful case because it shows the first approval date is not always the only policy relevant date under the revised orphan logic. The timelines begins with an orphan-related approval, which in this case for advanced melanoma. Then it moves to the first non-orphan approval, which is for the advanced non-small cell lung cancer. Under the revised logic, that later non-orphan approval can become a new starting point for the eligibility clock. The key message is not just about Keytruda. The deeper point is that life cycle sequencing now matters. The order in which a drug moves from rare disease use to broader market indications can actually affect when negotiation exposure begins. Previously, we mentioned MFP is usually published the next year after selection. And this renegotiation pathway tells us that the MFP is not necessarily a one-time endpoint. A previously selected drug may return to negotiation if it remains without generic or biosimilar competition, and if specified triggers apply, such as a change in monopoly status, a new indication, or a material change in the evidence or value factors. Tradjenta is the first example in the 2028 cycle. Its selection for renegotiation appears consistent with the program's criteria, given its time on market is over 16 years since its original approval from 2011. The policy idea is very clear. Medicare wants negotiated prices to reflect changing markets and clinical conditions, not only the facts available at the first negotiation. Now we'll be moving to the other moving parts in drug pricing reform introduced by Ina.
Thank you, Jean. So let's talk about IRA implementation after 2022. The CMS guidance plays a major role in shaping how the negotiation program works. It helps clarify which drugs are eligible, what manufacturers need to report, and how compliance will be handled. This guidance is also evolving over time, and CMS continues to update and refine it based on stakeholders' feedback. At the same time, manufacturers and industry groups have challenged the program in court. Their main legal arguments are that to focus on whether participation is truly voluntary and whether CMS has exceeded its agency authority. Because these cases are still ongoing, the litigation creates some uncertainty around how the program will ultimately be implemented. Another major piece is the Part D redesign and inflation rebates. The redesign eliminates the well-known donut hole, which Jane briefly mentioned, and creates an annual out-of-pocket spending limit for beneficiaries. In 2025, the limit was $2,000, and in 2026, it increases slightly to $2,100. And inflation rebates are meant to discourage drug price increases that rise faster than inflation. Outside the IRA's negotiation program, policymakers have continued to focus on affordability and supply chain reforms. Beyond OBBBA, which Jane discussed earlier, there are other moving parts in the drug pricing debate. But for this discussion, the two most important ones are MFN pricing and PBM reform. MFN pricing, or most favored nation pricing, is a form of international reference pricing. The idea is to limit US drug prices by capping them at the lowest price paid in comparable developed countries. The core argument behind this policy is that the United States should not be paying far more for the same drugs than other wealthy countries. MFN pricing itself is not a new idea, but it has recently reemerged in policy discussions. In May last year, President Trump signed an executive order titled Delivering Most Favored Nation Prescription Drug Pricing to American Patients, which formally launched the current version of this policy. When implemented, MFN prices are expected to reflect the lowest GDP per capita adjusted price in any OECD country, with a GDP per capita of at least 60% of the United States. The table here summarizes the key characteristics, impacted pharmaceutical benefits, and timelines for the three MFN models. One of these models, which is generous, it stands for Generating Cost Reductions for US Medicaid, has already been announced. Generous is a CMS-led Medicaid pricing model, and participation is voluntary for both states and manufacturers. That said, the broader MFN approach may still face legal and political uncertainty. Legal scholarship suggests that large-scale price regulation created through executive or administrative action can face judicial scrutiny and may be revised or reversed when administrative leadership changes. So PBM reform is another major part of the drug pricing policy debate. PBMs, or pharmacy benefit managers, manage drug benefits for insurers and employers. As shown in the figure, PBMs sit between manufacturers, insurers, pharmacies, and patients, so they play a central role in how prescription drugs are covered and paid for. PBMs have several important functions. They negotiate rebates, manage formularies, create pharmacy networks, and they also handle tools like prior authorization. Because of this, PBMs can influence which drugs patients can access, which pharmacies they can use, and how much they pay out of pocket. A major concern is that the PBM market is highly concentrated, and it essentially functions as an oligopoly. The figure here shows this concentration very clearly. Just three major companies, CVS Caremark, Express Scripts, and Optum Rx, they manage roughly 80% of prescription claims in the United States. This creates a significant market concentration and raises concerns about unchecked corporate power. The main PBM reform proposals focus on three areas. First, rebate reform would direct more rebate value to patients or plan sponsors. And then second, spread pricing reform would reduce the gap between what PBMs charge health plans and what they pay pharmacies. Finally, transparency reform would require more disclosure of fees, contracts, and also revenue sources. But there are also challenges to these reforms. PBMs can shift revenue across different contract structures, which means that regulating one payment stream may not fully change the overall incentives. And all these connect back to the IRA negotiation program. It only sets prices for selected drugs. Patient costs and access still depend heavily on PBM coverage decisions and benefit design. After looking at the policy updates, the next question is how these changes affect the broader pharmaceutical ecosystem. The IRA and related reforms do not only change government payment rules, they affect five major stakeholders, which are investors, manufacturers, patients, providers, and plan sponsors. And I will go through these one by one. First, let's talk about investors. The IRA affects how investors value certain drugs and companies. Drug development is expensive and risky. Because of that, any policy that changes future pricing can also affect how investors think about the value of a drug. But Medicare negotiation does not apply to all drugs. Eligibility depends on different factors, such as Medicare spending, how long the drug has been on the market, and whether there is competition. So investors are not evaluating only the entire pharmaceutical industry in the same way. Instead, they are looking at exposure drug by drug. One thing investors focus on is Medicare revenue exposure. Drugs that depend heavily on Medicare sales face greater pricing risk because they are more likely to be affected by negotiation. Another important factor is patent life. IRA pressure is layered on top of existing concerns about patent cliffs. So investors are looking at both policy risk and the normal loss of exclusiveness. Timing also matters. That's because small molecules and biologics have different timelines for negotiation eligibility. So investors would look closely at when a drug may become exposed to IRA pricing pressure. Beyond the drug level factors, investors also consider how much risk sits within the company overall. Like large diversified pharmaceutical companies, they may be able to absorb IRA-related effects more easily because they have broader product portfolios. But for smaller companies, especially those tied to one major Medicare drug, they face greater risk because a pricing change could have a much larger effect on their overall value. And then for early stage biotech companies, the impact is less direct in the near term because many of their products are not yet on the market or not yet eligible for negotiation. But still, future pricing expectations can affect how these companies are valued, and they can also affect acquisition decisions by larger pharmaceutical firms. More broadly, the IRA may shift investment priorities rather than reduce investment overall. Investors may favor drugs with lower Medicare exposure, stronger clinical differentiation, and of course, clearer value under pricing pressure. The IRA also changes how manufacturers think about their strategies. One possible response is faster uptake and earlier indications. In other words, manufacturers may try to generate more revenue earlier in a drug's life cycle before negotiation eligibility becomes a factor. They may also look for products with lower Medicare exposure or place more focus on drugs that have broader commercial demand outside of Medicare. And then there's also concerns about launch pricing. Some people worry that manufacturers may respond to the IRA by setting high launch prices for new drugs. But so far, there is no clear evidence of widespread IRA-driven launch price increases. Manufacturers still face several pricing constraints. Inflation rebates limit how much prices can increase after launch, and payers also continue to use coverage restrictions, and competition can, of course, reduce a manufacturer's pricing power. Because of this, the more likely response is a strategic adjustment rather than blanket price hikes. Portfolio rebalancing and indication sequencing may change as well. Manufacturers may become more selective about which drugs they prioritize and when they pursue additional indications. Negotiation may also become another planned life cycle milestone, which is similar to how companies already plan around patent expiration or competition. The impact will differ by drug type and market exposure. Drugs that depend heavily on Medicare are more vulnerable, while drugs with strong clinical value and global demand can still support investment. After all, the IRA changes how manufacturers plan a drug's life cycle. Since negotiation eligibility is tied to time on market and Medicare spending, manufacturers now have to think not only about total revenue, but also about when that revenue is earned. The IRA's biggest impact for patients is affordability. The annual Part D out-of-pocket cap makes prescription drug spending more predictable. This is especially important for patients who rely on expensive chronic medications or specialty drugs. The IRA also lowers cost sharing for certain high priority medications, such as insulin, which can make these treatments more affordable at the pharmacy counter. The main impact is concentrated among the highest cost beneficiaries. A relatively small share of patients accounts for a large share of prescription drug spending, so these patients are likely to see the biggest financial benefit. High drug costs can also affect medication adherence. When costs are too high, patients may skip doses, delay refills, or even abandon treatment altogether. So, by lowering out of pocket costs, the IRA can improve access and also help patients stay on their medications. Insulin is one example of this effect, with early evidence showing that lower cost sharing is associated with increased prescription fills. So the IRA does not just lower prices, it also reduces financial barriers that can prevent patients from accessing the treatments they need. For providers, the IRA does not directly control physician prescribing. Physicians still make prescribing decisions based on clinical evidence and patient need. But plan incentives and formulary design can still affect the prescribing environment. They can affect which drugs are easier for patients to access and which drugs have lower cost sharing. There is also a reimbursement piece here, especially for Part B drugs. Under the buy and bill model, providers acquire the drug first and are then reimbursed by Medicare based on the drug's average sales price, plus a 6% add-on, which is often reduced by sequestration and along with a separate payment for administration. As negotiated prices take effect, this reimbursement structure may change the economics around certain drugs. Because the add-on payment is tied to the drug's price, lower negotiated prices could reduce the add-on amount providers receive. So while prescribing remains clinically driven, the IRA can still affect the practical environment around prescribing through affordability, plan rules, and reimbursement incentives. And then finally, let's talk about plan sponsors. A plan sponsor is an entity that contracts with CMS to design, bid, price, and administer a Medicare plan, while also taking on financial risk for that plan. Examples include companies like United Healthcare and Humana. In some cases, plan sponsors can also be specialized companies that operate standalone prescription drug plans or Medicare Advantage prescription drug plans. Plan sponsors play several major roles. They submit bids to CMS, receive subsidies and premiums, manage formularies and pharmacy networks. They also bear risk within the Part D benefit design. The IRA fundamentally changes how risk, cash flow, and pricing power work in Medicare, especially in Part D. One major change is that the IRA shifts more liability away from CMS and toward plan sponsors. But at the same time, it caps beneficiaries' out-of-pocket costs and introduces government price setting through Medicare negotiation. For plan sponsors, that means higher risk, tighter margins, and more pressure to manage drug utilization and formularies more aggressively. But that may also lead to structural changes in market participation because sponsors reassesses whether and how they want to compete in the Medicare Part D market. So that brings me to the end of my session. For deeper discussion, we encourage you to read the full white paper, Medicare Drug Price Negotiation under the Inflation Reduction Act. And Licia has also put a link in the chat, and you can all go there and download the white paper.